today we're going to be talking about our very first case study, which I have put together based on what I see in the ER. And today we're going to be talking about chest pain. And there's something called the winter aches and pains. How many of you have heard this word, the winter aches and pains? So this is something I didn't hear in school while I was going through nursing school. But when I started work in the ER, I have seen so much that we never covered. And one other thing I want to let you know, even as we go on, is that you gotta find a way to build relationships with your providers, your doctors in your unit. When you talk to your doctors, it actually expands your knowledge base. That way, because you have questions, they are able to answer, they're able to discuss cases with you, and this sets you above your peers. So today we're talking about the winter aches and pains, right? The winter aches and pains. You might be aware that days get shorter during the winter. But did you know how that can lead to body aches? Less sunlight means less vitamin D, which in turn means that your body is missing out on a vital ingredient, vitamin D. Vitamin D deficiency can lead to migraines and body aches in the winter. Did you know that? I know you probably know about the deficiency of vitamin D, but do you know that it actually has anything to do with the winter body aches and pains? Did you know that's the reason why people have body aches and pains during the winter period? Lack of vitamin D. Now, the case study today. Here's the chief complaint. My patient comes in, it's a 40-year-old African-American male, presents to the ED at 04:15 in the morning, because I work night shift, right? So patient comes in 04:15 in the morning. He reports that 3 hours ago, he was awakened from sleep by worsening central chest pain that is radiating down his left arm. He feels significantly short of breath at rest and has been profusely sweating, diaphoretic. Now, he denies nausea, vomiting, or diarrhea, and denies any recent illness. The patient specifically denies a history of heart attack or venous thromboembolism. He reports that yesterday he was shoveling snow, right? But then constantly was running out of having shortness of breath. As he's shuffling, he developed shortness of breath and he had to stop several times. Now, he had excruciating chest pain with associated symptoms of shortness of breath. Extreme fatigue. The patient reports his only medical history is hypertension and high cholesterol, but admits that he has not seen a doctor in years. How many of you come across patients like that? Young man, he's 40, feels like he's healthy as a champ, doesn't see a doctor, but all of a sudden develops this chest pain. Now, patient was brought into the ER. If you're the nurse, what is your plan of care? What's your nursing care? What should be going through your mind when the patient shows up in the ER with chest pain, with that chief complaint I just gave you? Chest pain, shortness of breath, especially at rest when he's doing nothing, right? And he's otherwise healthy, denies any history apart from blood pressure and hypercholesterolemia. That's it. What are you going to do if that patient shows up? I'm going to, not to waste time. The first nursing step that you want to do, because the patient is actively having shortness of breath and chest pain, you want to place them on 2 liters of oxygen. The next thing is what? Get a 12-lead EKG stat. And it is supposed to be within the first 10 minutes upon arrival. Patient comes in the ER with chest pain. The goal is for us to get the EKG within the first 10 minutes. That's very important because every minute counts in chest pain, right? Obtain a large bore IV and draw labs immediately. Once you get in the IV, you're getting the labs. Get everything. Place on cardiac monitor. Maintain Nothing by mouth at this time, because you don't know where this is going to go to, right? And complete your head to toe assessment. Once that's done, that's your nursing intervention. That's what you're going to do as a nurse. Even before the doctor puts some orders, because you want to save that life right there. Now, and guess what medication he's taking? He's taking HCTZ for blood pressure and a sweet good old amlodipine. Atorvastatin for high cholesterol. Now, social history. He doesn't smoke. He doesn't do no drugs. But he does drink. He drinks 8 to 12 ounces of beer several times per week. He drinks. Family history. This is important. Do not forget when you're doing your assessment on your patient, don't ignore family history. Extensive family history of diabetes type 2. Father had myocardial infarction at the age 55. Older brother had MI at the age 50. What do you think is going on in his mind as a patient? If you were in his shoes as my patient, and you have your father died or had an MI at age 55, your brother had an MI at age 50, and you are 40 with this massive chest pain. Pretty obvious, right? All right. So pertinent physical exam. When I did my physical exam, of course, place him in the monitor, run the first set of vital signs. Blood pressure was 164/94. Pulse was 82. Temperature was 98.9. And respirations were 22. Key, SpO2, pulse ox, 94% on room A. Now, he's having significant shortness of breath. Don't you think that the SpO2 actually correlate with the shortness of breath? So our 2 liters of oxygen or our 3 or 4 liters of oxygen, depending on how the patient is doing, is actually essential. That's a good nursing intervention for you to do. Complete physical exam are within normal limits. Ongoing assessment now. As you are in the room talking to a patient, you realize patient is sitting up in bed, clutching his chest, distressed and profusely diaphoretic. Cardiovascular, what do you find when you listen to the heart? As you're taking the pulse, what you're finding. So as I was doing that, of course, you find a non-tachycardic with regular rhythm, normal heart sounds without a murmur. No JVD was present, jugular vein distension. No costochondral tenderness. The heart feels normal, but he's in pain. Pulse +2 at all extremities, palpable. Okay, respiratory. Moderate respiratory distress, increased respiratory rate, speaking in full sentences, clear breath sounds bilaterally as you listen to the lungs. Extremities. Distal pulses are intact. As I said again, +2 bilaterally with no pitting edema. So he otherwise looks healthy, but the only thing that is bothering him today is chest pain and shortness of breath. So we ran the first set of labs, and the results came back with pertinent diagnostic testing results as CBC, CMP, PTT, PT, and INR, all unremarkable. Yeah? That's pretty typical. Sometimes not for diabetics. What do you think? Let me know what you think as we're going through this. If you're a nurse, please drop your comments. Hit me up. Let's talk. Have some constructive conversations and help each other learn. But this is what I want to point to you. I've given you the pertinent diagnostic testing. Did you ask if we did troponin? Anybody did? No. Okay. But we did troponin, right? As part of the labs, it's a cardiac marker. Troponin, though, it will surprise you. It was 7.56 nanogram per ml. And the normal range is supposed to be less than 0.06. But this guy shows up with 7.56 troponin. Now, the portable X-ray showed that lungs were clear. No atelectasis. That's an otherwise normal X-ray. 12-lead EKG. Remember, 12-lead EKG was done within the first 10 minutes. And the doctor signed off on it. It shows the sinus rhythm. Rate was 82, poor R wave progression, slight ST elevation in AVR, upsloping ST segment depression with hyperacute T waves in the anterior precordial leads, consistent with the De Winter T wave pattern. ST segment elevation. In nursing school, this was something that they drill into your head. ST elevation, do something. ST elevation, let the doctor know. ST elevation with associated symptoms, act, intervene. Our plan, what we did, the patient was placed on a cardiac monitor, of course, and a second large bore IV was placed. ST elevation changed the cost of things because the patient is actively having chest pain, shortness of breath, diaphoretic, so he is symptomatic. So we get a second large bore IV because we're about to start pumping this patient with medication. The patient is administered 324 milligrams of chewable aspirin. Bingo. First medication therapy. Aspirin, chest pain, 324, right? That's the first thing we do. Second thing, because the pain wasn't changing even with aspirin, we did nitroglycerin. How many times do we do nitroglycerin for a patient that is actively having chest pain with elevated blood pressure? Somebody guess? 3 times at intervals of 5 minutes until the pain has resolved. After the, you can stop after the first one if pain is resolved. But if the pain is still there, there's nothing changing, you have to do up to 3 rounds of nitroglycerin sublingual. So we did 400 mics of nitroglycerin sublingual. First time, didn't work. Waited 5 minutes. Took vital signs. Did the second 0.4 milligrams of nitroglycerin. Nothing changed. Waited 5 minutes. Run set of vitals. No significant change. And the last round of nitroglycerin was administered this time. Now his blood pressure came down to 124/82 after the third dose of nitroglycerin. In consideration of his presentation and EKG, cardiology is paged for emergent cardiac catheterization. What do you do as a nurse? Once cardiology is paged, the doctor talks to you, hey, this patient is going to be rushed to the OR. What are you supposed to do? You prep for surgery, right? You prep for surgery. You begin to prep because the patient is living straight from your emergency department to the cath lab, and you have to prep all that. If that might be a different video talking about prepping a patient from the ER to the OR. But did you even bother to ask me what the specific diagnosis of this patient was after seeing the EKG? Alright, I got you. So the diagnosis though was an acute unstable proximal left anterior descending coronary artery occlusion. I'll say it again. An acute unstable proximal left anterior descending coronary artery occlusion. That is an artery that is supplying the heart with good chunk of blood. In other words, it's actually simply a myocardial infarct. MI, myocardial infarction. Now, came in right on time. And based on the prognosis, when the patient went to the cath lab, we were informed that his procedure was successful and he's doing fantastic. He got stented, right? Got stents placed in his heart, which opened up that artery and allowed proper perfusion of the heart, supplying the heart with oxygen, and his heart is doing, I believe, fantastic. Patient did very well going through this, but not all the patients get this good, come out so successful. Sometimes it goes downhill. That's why the ER is what we call unorganized chaos, because you never know what to get. All right, Sojourners, much love. Keep doing what you're doing. Do not allow your nursing flame to go off.